will be totally mindful of your time, Melissa, today.
Yeah.
But just so everybody knows, we've been friends for many, many, many years. Started our friendship working kind of at odds, if you will, on legislation for preceptors. And it's just been a really neat opportunity to work with you in a number of different ways. But most of the time, people don't start their friendship out with having completely different opinions about a topic. That was a really good thing that we did. And so together we worked on the preceptor tax credit for Colorado. So just kind of a neat thing. So Melissa, I know you and how wonderful you are, but I really would like you to just kind of introduce yourself and we'll go from there.
Okay, that sounds great. And Monica, I love the way that you phrased that and articulated it. It's exactly true that we had a common goal, we had a common passion, but we were entering in very different directions. But I think we still met the outcome that we were wanting to achieve, and it just demonstrated that there's so many passionate minds that are fighting for rural health in Colorado, and we can find a way to work together, and it lasts into many, many years. So I would agree with that. Yeah.
And you can't say that about so many relationships. Usually it's like if you start off on two different points of view, you don't come to terms. And now Melissa's my go-to in Northeast Colorado, oftentimes, if I have a question about what really is going on with the hospitals.
Yeah.
So just super neat. And we've become friends. We're both moms and love that challenge that presents. So
exactly. Yeah.
So you have a fancy title, Executive Director of the Eastern Healthcare Consortium. And I know that's one of the many things that you do. And I think kind of for today, we want to focus somewhat of this conversation into tapping into your expertise on rural healthcare and maybe explain what the Eastern Plains Consortium is and kind of one of your brainchildren.
Sure. Yes, it's definitely, I consider it one of my babies. I love it dearly. So back around 2015, I can't actually take the credit for all the idea of the consortium. Kevin Stansberry, who's the CEO of Lincoln Community Health in Hugo, Colorado, which is right outside Lyman. It's funny to say that there's a suburb of Lyman, but it is. He started noticing that we needed to be more proactive on keeping rural hospitals alive and open. And he saw, well, we've all seen that so many of our rural hospitals are either being acquired by large health systems or just shutting down. Since the Affordable Care Act came out, more rural hospitals have closed than in any previous years combined. So it's really a devastating problem, and the hospitals on the Eastern Plains are in jeopardy of closing due to finances every day. I mean, month to month is really a struggle, and most of them are operating within the red. So 2015, Kevin got this idea about why don't we disregard, the football game 20 years ago and the infighting over tractors or whatever it may be, and let's start talking with the other hospitals in the Eastern Plains to say, how can we start working together and being proactive and sharing resources to create economies of scale that will keep these hospitals independent and open. So at that time, I had just left the Rural Health Center, and Kevin had approached me to start bringing some life into his baby or his dream child. And so we actually did all this work pro bono for about 2 years until we got some grant money, and we are primarily sustained on grant dollars now. But we started out with 4 hospitals. We're now up to 9 hospitals and a health system member, Banner Health. And we are looking at expanding into southern southeast Colorado with 4 additional hospitals. So that would equate to more than a third of the critical access hospitals in the state. And as far as the structure, we are a 501c3, so we're a nonprofit, and each CEO has a board seat and a board vote. Banner Health has 1 seat and 1 vote too. We did that intentionally so that the majority of the voice could still be from those independent rural hospitals. So that's kind of how we began. Would you want me to go into some of the programs and offerings that we provide?
Yeah, that would be awesome too. So there was clearly a need to create some economy of scale for the hospital systems. But how did you take just that idea and the fact that they were all losing money? How did you bring them together to create some really meaningful change in different programs?
It's a great question. And to be candidly honest, it took almost 2 years to start to really get that trust among the hospitals. Rural communities are very resilient and very, very independent, but we had to start at ground zero with saying that, the work that we're doing is trying to support and help each hospital versus taking over or merging any of the services that they already do. So I would say that still a big portion of my job is developing and fostering that trust among the different hospitals. So we have grown though with some flagship programs that we feel are really important and are continuing. So the first one is our nurse share program, where we are able to create a pool of nurses that are employed at each hospital. And we've developed a platform so that shifts can be picked up by nurses from hospital A, and they can go to hospital B and get reimbursed for working those shifts. This has helped the hospitals because they have been able to really reduce the cost of their temporary nurses or their locums that they were paying. And we also have a vision for it expanding much broader than nurses. So we've started incorporating radiology techs or some of those other positions that we don't think of normally as being really vital, but they're always having a shortage in that area. So that's already shown some significant savings. Our Banner Health System member, they have actually helped us quite a bit. They have a goal of saving each of the hospitals $100,000 a year, and it's coming out in different sorts of ways. Our group purchasing is through Banner Health, and so we're able to negotiate even a lower cost for supplies and equipment through that, but then also some other things like even contract maintenance on large equipments like MRI machines or CAT scans. Banner is able to help do that at a free or very low cost rate for our members. They also have helped us with legal services, a lot of other services that we would have to pay, thousands or hundreds of thousands of dollars to achieve when we can use them. The major program that takes up the majority of our time right now is actually we've been into policy work, specifically at the federal level. So working with the Centers for Medicare and Medicaid Services Innovation, which started around the Affordable Care Act. We've been out to Baltimore to talk to them and made some proposals. We've also been pivotal in some state work with the Healthcare Policy and Financing, which is our Medicaid office. So we are redesigning the way that we participate in their programs, and we're able to do that with the collective voice and at a regional level versus each hospital trying to do that independently. We also have received a pretty substantial grant, and Kim Farley on your team, Monica, has been so wonderful in providing extra resources for this. So we're working on behavioral telehealth and starting with emergency services and moving then into primary care. And we hope to expand that even further too. So I think I went off on a tangent, not even your particular question.
There are no tangents. We're just a bunch of friends talking.
Okay.
I have a couple questions though. So the hospitals, when they join the consortium, is there a fee for membership?
There is. So members pay $1,200 a year, although it's more important for us to have inclusivity with the whole Eastern Plains. So there have been times where, hospitals are saying, we can't afford $400 a month even. Okay, it wouldn't be, I'm doing my math wrong. It's $400 a month for a membership, which times 12 would be something I should know. Did you say something, Samantha?
About 5,000.
Thank you. Okay, you can tell I'm not a math professor or a major, but the point I was trying to get across was that it really, their membership isn't dependent upon their ability to pay the dues, because sometimes they can't even pay that much toward the dues. So, but yes, they do have an assessment.
So just so we all have a feeling of who the hospitals are.
Yes.
So the larger hospital is who in the consortium, and who's the smallest hospital?
Right. Great question. So if we take Banner out, since they're a system, I would estimate that the largest hospital is Ray Community District Hospital, which is in Ray, in the county of Yuma. The smallest one is probably, I would say, Wisebroad Memorial Hospital. They are way south, like south of I-70 in Eads, Colorado, and they have, I think, 4 active beds in their hospital.
So because I know that some of our target audience who want to learn from you are nurses, and nurses have really been challenged historically in the region, but also with COVID. And this is going to be putting you on the spot. So when you start, so how is this consortium going to benefit nurses and human capacity in the area?
We know that nurses are so many times kind of the foundation of our healthcare system in rural. They are doing so many other things just besides nursing. A lot of times they are also the quality director. In 2 of our hospitals, they're also the chief nursing officer in addition to the CEO. So they're wearing many different hats. But as far as how the consortium is helping nursing, I think our staff share is taking a step toward that. But we were recently just awarded a grant with HRSA, which is the Health Resources and Services Administration, in partnership with the Colorado Center for Nursing Excellence, so CCNE. And that is working on being able to provide nurse leadership and mentoring. So it's a curriculum where it's growing nurses at the RN level and helping them get into advanced nursing practice, and also just providing a community where they can learn and share with each other. So that's a 3-year grant. Additionally, since I am a professor at Regis University, we are looking at starting a program that will help streamline MAs or CNAs into an RN learning opportunity at a much lower discounted tuition rate. We're also discussing how can we potentially create a sim lab out on the Eastern Plains so that you can really grow that pipeline. What do we call it, Monica? The grow your own pipeline.
Wow.
Yeah, for nurses. So allowing nurse students to learn and grow in their communities instead of having to leave to the city and then come back.
I love the idea of the sim lab, and it's something that we've been looking at here at COHAC as well. And the Western Colorado AHAC provides a wonderful online curriculum for CNAs, MAs, and we would love to partner on the creation of how can we then translate that into workforce in Northeast Colorado. So as an aside, we can chat about that, but great opportunities for helping build the capacity of these hospitals.
I would love to be involved. Thanks.
Yes, and maybe someday we can actually meet face to face.
No.
Yeah. So talk to me a little bit about, both you and I teach, and some of the fundamentals are before you do anything, go into the environment and do a economic, financial assessment, SWOT, environmental review. Did you do any of those?
We actually, in 2019, so they need to be updated peri and post pandemic, but we did community health needs assessments on all of the hospitals. And we did it kind of the standard view, but we did add a financial component there too, to really understand where each hospital was and where some hospitals can help others. So that took a lot of trust too in the CFOs and the CEOs being willing to share their financial information. It's public because they're all, none of them are for profit, so you can look up their finances, but it still took a lot to come together and really grasp that. So we have a good landscape assessment or environmental assessment of each hospital individually and each community individually, but then we identified some regional trends, like where do we see, you know, the most financial need across the region, the population health outcomes. So where are the strong points in the region, where are the poor points? And we intend to use these in multiple different ways. First, around our policy work to show, as many of the urban hospitals are, you know, showing significant profits every year. These rural hospitals are not, but they're getting lumped into all of the other statements about hospitals being so profitable. Then some other ideas about down the road, we would love to work on a centers of excellence where we can keep people in a rural setting to get all of their healthcare, or the majority of their healthcare, but then also support the volume needs in each of the separate hospitals. For example, like Lincoln Community Health may employ all of the behavioral health specialists that can then be centered as kind of the hub for the rest of the consortium. Or one hospital like Ray, since they have a residency, they may do more specialist care, like around orthopedics, for example. And the other hospitals can send their patients to Ray. So the economic impact is still staying within the rural community, but the scope of services can still also be achieved staying in the region.
Just some really great ideas. And one of the questions that I wanted you to share with us is you've done these assessments. They've showed each other, if you will, their laundry. What makes one of the facilities more fiscally solvent than another? Are you seeing a trend, or is it just sheer luck?
Yeah, I think some of it is sheer luck. I do think that leadership does play a role, and in the governance. I think maybe the biggest indicator is the payer mix. So what does their population look like as far as publicly insured or privately insured? And as you go north of I-70, there's actually a lot more wealth. So the payer mix is more heavily private. As you go further south, like any of the hospitals south of I-70 are upwards of 80% Medicare or Medicaid covered. And so they struggle a lot more. That said, there's also the very controversial contract negotiations that occur with the private payers. And this is something we would love to fight. We haven't formally fought it yet, but it is illegal for one hospital to share their rate reimbursement for private insurance with another hospital. And we're trying to see legally how we can share as a consortium and aggregate that data. We don't have that yet, but we don't know. We have some inklings just based on the finances, but we don't know specifically what hospital A is being reimbursed for private insurance versus hospital B, C, or D. So I would say that if we had those numbers and that data, we could really show that it has a lot to do with the commercial payer too, as far as being fiscally viable. I would also say that just physical plant would come into play as far as viability. So the Hill-Burton Act came out in, around 1951, I think, and tons of federal dollars were put into the system to build new rural hospitals. Some of our hospitals have not had many improvements other than just maintenance since 1951. So some of these hospitals are working out of very, some of them are kind of dilapidated right now, buildings, while some others their communities have rallied and started mill levies. or donated to actually build new hospitals. But I would say that some of the hospitals that are hurting the most are those with the oldest facilities too, because they're always trying to play catch up on their boiler or their HVAC system or all those things that continually go down.
Don't you think it's really interesting that I, as a consumer, can get the cost of an MRI and do individual cost comparisons so we know how much the procedure is going to cost me? And everybody will know hospital A is more expensive in MRIs than hospital B. They know that in the region. But the consumer knows that, but what the consumer doesn't know is the back end of this. How much are the individual hospitals needing to recoup? So you may have one hospital saying, I'm going to do an MRI and my cost is X because I have to recoup 50%. You may have another one that says, oh, we'll do the procedure and we only need a 20%.
Exactly. You hit on a point that has been so many spirited conversations at our board level, which I think is really vital and important. So yes, the public doesn't have all the accurate information to make a really informed decision and also keep the hospital in their community open. And with each hospital is one of the top 3 employers in their community. So if that hospital closes, the entire community is really in financial detriment. But to your point, the Eastern Plains in Colorado has the highest premiums of any region in the state, but are reimbursed the lowest. So the Rand Corporation came out with a report last year, I think, that showed aggregated by region what reimbursement levels are. And we are shown that the Eastern Plains, all of the hospitals within there are reimbursed at the lowest amount, but still have the patients there still have the highest premiums in the state. So that doesn't make any sense as far as financial stability, and nobody, even the insurance commissioner, has been able to tell us why. Another thing that we're fighting consistently is commercial payers will authorize an MRI or a CAT scan almost immediately if the patient goes to Denver or to Greeley, but they will not authorize it to have it done locally at home. And so the patient automatically assumes, well, it's only going to be covered if I go into the city for this. And the hospital staff have to fight and call and try to get those pre-authorizations before the patient has already gone up to the city. And it takes usually 2 or 3 weeks for that authorization. And for many people needing assessment like that, they don't have the time to wait that long for that authorization. So it's a really, really sore spot right now.
Mm-hmm. What about the difference between profit and nonprofit? Are you seeing a difference in the quality of care? Are you seeing a difference in the cost of care, overall satisfaction?
Right.
What are your thoughts about that?
This is something I talk to my students about a lot, just the differentiation between the for-profit and the nonprofit. And the Eastern Plains hospitals are all nonprofits, whether it's a 501c3 or a district hospital, they have that nonprofit status. So I think that a lot of it comes down to, at the larger level, what their governance looks like. So we're for-profits like HCA, the leadership has to respond to their shareholders. It's a much more intimate kind of setting where a nonprofit has to report to their board of directors that meets regularly and are involved not only just in the financial stewardship, but then a lot of times more. They shouldn't be involved in the operations, but they are more often than not. What I've seen too is, especially during COVID, boards are getting anxious and scary, and so they are turning over the CEO versus working and keeping that stability in this time that's really needed. So I think when that leadership moves, then that does affect patient quality, patient satisfaction, because everybody has to regroup and figure out what they're going through again. But I'm not seeing any difference in patient quality due to the nonprofit, although there may be. Actually, my mother tore her meniscus a few years ago, and she was not getting help from HCA or Health One. That's part of a for-profit. So I actually took her down to Melissa Memorial in Holyoke to get her meniscus repaired, because I knew that she would receive that really individualized and personalized care, which she did. And her recovery was about a third of the time that was projected from the urban center. So I think that there is, but it's just not, we need to measure it better and really understand. I think another example is our rural hospitals know long-term care and rehabilitation so well, because such a dense portion of their population is over 65. They know how to care for people in long-term ways, and then also with chronic disease and all of those things that come along when you age. And during COVID, we've actually been able to take patients that are recovering from coronavirus and move them into some of our rural settings and then send them back home once they've rehabilitated. So I don't think that would happen in a for-profit rural setting either, because it all has to do with that individualized care.
So thank you for that. And your mom's doing fine now?
She is. She's in remission from lung cancer. Tell you about 2020. She got diagnosed. I told her she never does anything easy. She gets diagnosed with lung cancer during a pandemic, but she's in remission now. So thank you for that.
She's good. Well, let's talk about, we can't talk about 2020 if we don't talk about COVID.
Yes.
So you said earlier that so many of these hospitals are struggling. They're struggling in the best of times. And then we throw in this whole COVID experience. We've been doing individual interviews with healthcare workers and just listening to these amazing stories of resiliency and perseverance and creativity. And that's what people are talking about. We're not hearing some of the other just less than disparaging comments. But what do you think's what's happening now? Is COVID going to push them over the brink, or is it going to bring these facilities together because they're kind of fighting a common enemy?
Right.
What's your ball?
I think yes to all of those. I mean, if we look at the finances, so just between March and April, the cumulative loss among the Eastern Plains hospitals was over 70% of their revenue. They weren't seeing a whole lot of COVID patients, but they had to basically shut down their services. And because of broadband and funding and reimbursement and low staffing, telemedicine was longer to pick up in a lot of those hospitals. So, I mean, some of my hospitals, like Melissa Memorial, for example, had to furlough and lay off significant numbers of staff during that time. Many hospitals were having discussions with their boards. Do we have to close? Do we have to shut our doors completely? The CARES Act infused a bunch of dollars into the hospitals. Some of the hospitals have started using that. Others have put it in a bank account and it's just sitting there. And the reason that they've done that is basically because the Department of Health and Human Services has not put out really clear guidelines about what that money can be spent for. And so many of the hospitals are afraid that they're going to be asked to pay that back, which they would not be able to do so. So the guidelines were very clear for urban hospitals that were seeing huge amounts of COVID cases, but it was really unclear as far as whether that money could be used for the secondary financial impacts and of revenue loss from outpatient procedures. So they are still struggling significantly, and it's day to day for a lot of these hospitals. What we're seeing now, though, is, and what was kind of projected, is the urban spread of COVID is now starting to hit the Eastern Plains, and it's hitting them pretty hard. I think there's a financial aspect, but there's also a social aspect. It's creating this large divide between community members and the hospitals. One of my CEOs said that 75% of their community believes that COVID is still a conspiracy. So asking people to wear masks, to socially distance, and having that hospital be one of the advocates to, be safe during this time is really splitting the community from the hospital right now. So that's a really, really difficult time in addition to this whole conundrum.
I have a question for you.
Yes.
So you talked earlier about how what you do a lot of is fostering that trust with the hospitals. And so I'm just curious how those strategies of fostering trust and communication might have prepared the hospitals to work through the COVID pandemic and maybe preparing them for working with the community who are now kind of being ostracized a little bit by that, what you were just talking about.
I love that question, Samantha. Very bright student. You're going to do amazing things when you graduate, and I'm sure you already are doing amazing things. So I think that we would be in a much worse spot if we hadn't have done all those relationship building things. An example how people came together when PPE was really, really hard to come by. We were coordinating masks and gowns and stuff to be flown out from Denver, and we have a group text where it's all of a sudden, okay, the pilot's going to show up at this time in this community, and all of the other CEOs come together and they're on there on a Saturday in their jeans, all meeting and having coffee and waiting for the PPE to arrive. So that's one area. I do know too that since COVID, we've started affinity groups with the other C-suite level executives. So we now have a CFO group, a quality directors, a CNO group, and an HR group. And they are organically now calling each other, driving to each other's hospitals to pick up supplies, sharing their budgets, asking for advice from one another, coming to me and saying, hey, can we start, X, Y, and Z in response to COVID as a consortium. So I think all of these natural organic things that are needed to just make it through today and then make it through tomorrow wouldn't be happening if we hadn't have built those relationships over time. That's it.
Well, and it's been a lot of hard work.
Mm-hmm.
And it's just wonderful to see that in some cases, the local governments are not coordinating their activities, but this group has brought the hospital systems, who, like you say, are often the major employers or one of the major employers. So just very interesting to see what sitting down at the table and discussing.
Yeah, and you bring up a really good point. Most of our public health departments do not have a relationship with each other across the Eastern Plains. Some of them have had a controversial relationship with the hospitals from time to time. And through the CHNA process, we were able to bring in public health and do it more of a partnership. But I think that's an area where we could really join forces and try to bring some of those public health departments together, because we have to be in partnership with public health to get through this pandemic. Another instance of that is the county commissioners sometimes are at odds with each other, and a lot of times it has to do with a tractor sale or a high school football game. But we are going to need those commissioners as we start developing some insurance alternatives for a regional basis, so that the hospitals and the communities are not reliant on these ridiculous premiums or the really low reimbursements from commercial payers. But we need those commissioners to be on topic with together. And so far, the minimal communication that we've tried to do as a collective with commissioners has not gone well. So we'll need to be spending a lot more time devoted to that.
There's always so much work to do, but it's definitely rewarding, and you can see the outputs. Just a couple final thoughts. We are definitely looking at telehealth. Mm-hmm. And how do we transition to telehealth, and how is that going to work in our rural communities? Rural people, we hug and we use our hands to talk, and yes, we're hearing really mixed reviews from people who are now experiencing a telehealth appointment and some of these mixed reviews have to do with limited broadband, unfamiliarity with computers. But we're not hearing that the delivery of the information isn't quality.
Right.
But we're hearing it's not organic, and it's a very different, it's almost anti-culture, if you will, in some regards, to have this kind of a personal setting. And so what are you seeing with telehealth, and are you seeing telephones, that the ability to reuse the telephone as an option to telehealth, because it's now billable?
Right. I love when my CEO says that the telephone is the original telehealth or telemedicine, and you can do so much from that. And there's been empirical evidence in published journals that show that the quality and the outcomes are pretty high. I mean, the providers know what they can do through a verbal assessment versus needing that physical assessment. So our quality providers are excellent, and we need to foster that. I think we also need significant partnerships like between EPHC and COHAC, but then also who are those community ambassadors on the ground that we can get into where these community members are and help to educate on the growing different platforms that are out there. I think COVID has, if you can find a silver lining, it's really pushing the innovation to the awareness of us in healthcare specifically, where there's so many innovative things happening right now. For example, we're looking at a company called Baby Scripts that wants to do a pilot, and only 2 of our hospitals out of the 9 actually birth babies. The rest will do prenatal or postnatal care, but there are only 2 that actually do. So this platform would bridge that gap and help drive our patients to those 2 hospitals, but then also education along the way. So I think it's for critical and triage and treatment, but it's also it can be used for that education piece that then leads to better outcomes, meaning healthier moms, healthier babies as that comes out. So that's one piece. I found something really interesting. We did a survey and found out that it's the older generation that is happily utilizing telehealth more than the younger generations, which I thought would be the complete opposite. But the older generations are not wanting to leave their home. They're more scared of getting out and about. Transportation and just moving around might be an issue anyway. So I think the unintended consequences of telehealth will be even far-fetching. But we have to partner together. I don't think we can have too many minds on how to get telehealth out. And while we're doing that, use the telephone. And we should use the telephone continuously because it's going to offer that link that we think may not be sophisticated enough, but the literature is showing that yes, it is.
One of the many things I appreciate about you, one of them is you are the true Pollyanny, if you will. But always looking at it from a really good point of view. We are working in a new population for us, and it's the jail population, and looking at the transition to care model, if you will. And that, I don't think we would be looking at that had we not had COVID, had we not seen across the state and in our region really failures to provide care to oftentimes congregate living environments. And so I think that's, if we learn anything from COVID, it's we can do this better. Right. And that there are gaps, and how we respond to those gaps will really be how history is going to remember what we did with COVID. Mm-hmm. And it's just super excited that you guys are out there working so hard. COHAC is definitely here as a partner to do whatever we can in the educational space, and we can talk offline about transitioning care and what we think that might look like. Mm-hmm. But I really do think that there's some opportunities for bringing the judicial system, which often is the other major employer in some of these counties.
Yes.
And why aren't they talking? Mm-hmm. And how can we bring that together, not only for community sustainability, but just overall population and making these communities stronger. So more to come on that one too. So
yes, I am so excited that you're getting into incarcerated populations, because we need a whole cultural ideal shift too, as far as our hospitals, about them really being community members that you need to serve. And our largest penitentiaries are in rural areas in the state. I mean, we have some of the largest federal ones here in Colorado. So
and in real rural communities. I mean, and when you have population inmates that exceed the general population, that's an interesting activity occurring in the community. So
it is.
What other questions do you have? As a future healthcare worker, does this scare you?
I think kind of what we talked about a little bit, just like how important it is for different organizations to be willing and prepared to work together. So it's really nice to be able to talk to you and see that it is possible, and we just need to teach those skills to the public health organizations, governing bodies, and things like that.
It is. We need change makers like yourself. I tell my students this all the time, because yeah, I always wonder, I'm always doom and gloom when I go into some of my, first courses with students, but to let them know that you have the ability, the passion, the innovative thought process to make the changes that we've been trying to make continuously. So there's a quote, who said it? Isaac Newton, standing on the shoulders of giants, that what we do in our role, you will then have to carry on and readjust it and move it to make it even better, because I think it's going to take multiple generations to get where we actually need to be. But yeah, we need you. So even if you are scared, continue on. You can make it happen.
So I like that you bring up, I wanted to ask you, because you're both an educator and a driving force in working with the hospitals, I want to know what you think is some of the most important skills that, like, my generation, like the students who are coming forward, need to be fostering in order to really be prepared and be participants with you guys in the future.
That is a phenomenal question. I think that we've spent, at least since I've been involved over the past 10 years, really focusing on clinical. And while clinical will still be a major concern for rural, we need to spend a lot of time fostering the administration. And I say this with a bias, because my education is in healthcare administration, and that's what I teach. But I end up talking a lot of my nursing students, physical therapy students, into at least a minor in administration as well. Because while clinicians are making the mission come alive and actually doing it, the administrators are the ones that are creating the foundation, and they're providing the framework, they're providing the house that actually brings the mission, allows other people to bring that mission alive. So administration is not just hospital CEOs. I tell my students this too. Usually they come into the practice wanting to be a hospital CEO. We need so many more different types. And so CFOs, financial is a huge, huge need. We need human resource professionals. We need, even department directors, all of those different kind of C-suites we need. And then also, on the other hand, care doesn't just happen in a hospital or in a clinic, it happens in the community too. So I think we need to be bringing a lot more professionals into public health, and then also those that can bridge human services into healthcare and public health. Because if we're going to really reach health equity or that wellness state, we're going to all have to work together and realize that we're not siloed in the work that we're doing. So I don't know if that helps at all.
No, that is a wonderful answer. Thank you.
Good, good. Yes, and your options are endless too, as far as when you graduate. But do love rural.
But you should always want to work in the rural community. Yes, we want to focus the rural community. Yes, exactly. Well, my friend, thank you so much.
Thank you. It was.
Yes, we will get together and let's talk in a week or so, because there's some projects that I think you can certainly at least highlight and let you know what we're doing. And Kim is out there doing amazing things, and Erica is as well. So it is our region. We are here to work you and do what we can because it's that important. So thank
I
you.
agree. Thank you. We need to pull our brain trust together. So yes, we'll get together. And it was such an honor that you even asked and to have this audience. And it fills me up knowing that there are other people that are working toward the same goal.
Aw.
Yeah.
Hang in there. Go hug your son and tell your mom hi for us.
Yes, yes. Hug all your family too. And
Okay.
be safe. Be well.
My friend. Thank you.
Thanks.
Bye.
Bye.